Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase them all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we will be talking about the infrapatellar fat pad, a structure that you probably thought, I could forget about this after anatomy class.
I'm actually really excited to be talking about this, and I'm glad you looked into it because I do also agree that it is something that is often forgotten.
Yes, I would agree. That's what made me, because I actually have someone that I'm kind of like, I think your fat pad's messed up.
I mean, isn't that the goal of like what clinical research is really for? Like when you have someone who you have like questions on, like you're supposed to go back and, you know, like look at the literature, like figure out what the research says about this topic, and then you can make better clinical decisions.
Yeah, honestly, and that's what is a big, like, kind of inspiration for a lot of these education episodes. It's just something that I see and I'm like, oh, let's look into this more. Hey, why don't we make an episode on that?
So this is a CEU episode, good for Category A CEUs. Thank you so much to Clinically Pressed and Athletic Training Chat. So if you're interested in getting your certificate, make sure you head down to the show notes and click on the link below so you can enroll in the course. If it's within our latest couple episodes, it is free. If it is not, it is still very affordable, and half of the cost will go towards supporting the show and half of it will go towards donating cold tubs to athletic trainers who wouldn't be able to get some otherwise.
Yeah.
So if you guys are new to these CEU episodes, Randy does a lot of research article reading, and you can find those references on our website. And then we will talk about this conversationally, and it's good for CEU. So let's go ahead and get started. What are our objectives today? What are we trying to hit?
Yeah, so we're going to describe the anatomy and what you don't think is the biomechanics of the infrapatellar fat pad. Discuss the evaluation of the infrapatellar fat pad, and then discuss the non-surgical management of the infrapatellar fat pad pathology, which is actually really interesting, and this is what kind of makes it hard looking into the fat pad, is a lot of the research is geared towards surgical intervention or kind of ways to preserve the fat pad during other surgeries, which is kind of interesting because there's a lot of kind of stuff on like the possibility of the fat pad being a complication in ACL reconstruction because of the portal holes.
Oh, that is fascinating.
Yeah, and so there's some other anatomy that we are now going to be jumping into that might ACL and fat pad be related.
Sweet.
So the infrapatellar fat pad is located in what's kind of referred as the anterior interval of the knee. That's basically the space between the tibia and then the patellar tendon. So that kind of like little triangle of space is where the part of the infrapatellar fat pad kind of sits in. The overall anatomy looks like this. The posterior side of the fat pad is the actual synovial lining of the knee. So you could see if there's some issues there, it presses on the synovium, which then creates swelling around the knee, right? So building the connections.
But also benefited by movement.
Yes, exactly. There are some connections from the fat pad to the ligamentum mucosum, which if you're like, what the hell is that? I've never heard of that. That's what could develop into a plica. Right? It could be the remnants that develop into a plica. If it's not a plica, it is just a smaller ligament. But this ligament does go into the intercondylar notch, and there are actually some connections to the ACL.
So this is really interesting because I've one of the surgeries that I've observed of an ACL reconstruction. One of the surgeons was saying that he was going to remove the plica because it was giving him difficulty of moving or of getting the proper angle.
Ooh, that's interesting.
So hearing this and like the connections and where those are, it's really fascinating to like really connect those dots.
Right? Isn't that cool? Yeah, when I was reading it, I was like, the fat pad basically connects to the ACL. That's crazy, or at least close to.
I mean, everything's really connected.
Yeah, that's so true.
Think about it.
To further the connections of the fat pad, because if you haven't guessed, it pretty much connects to everything in the knee. It actually does have attachments to the proximal patellar tendon and the inferior pole of the patella. It'll attach to the medial and lateral meniscal horns, and then part of that anterior tibia, just like kind of superior to the tibial tuberosity. There's even some literature that shows that it actually goes as high as the medial and lateral sides of the patella. So this is a pretty big structure overall. I think one key part of the anatomy that I think a lot of people don't appreciate and what makes it unique and what could make it very important is its innervation. The infrapatellar fat pad is rich with free nerve endings and nociceptors, which means there's a lot of nerves in there. And if things are bothering those nerves, you're going to feel it. I think there's this study, and it actually is, like, I heard this, I don't know if it was social media, but it's actually referenced in a few of the articles that I read, that this surgeon only did like kind of a local anesthetic and was probing different structures in his own knee.
Oh, I saw this.
Yes. And the most painful structure that he probed was the fat pad.
That's crazy.
Yeah. And so when you hear it on social media, you're like, okay, that kind of sounds fake. No, it's actually referenced in literature.
Could you imagine what? I don't think I could ever do surgery on my own knee.
Yeah, that's crazy. That's why I should have read that actual article. I should have found it. But it just shows like this structure could actually be really key to anterior knee pain. So like think of your patellofemoral pain syndrome, right? Hey, how many times have you purposely like, I'm going to evaluate the fat pad?
You know, I feel like it is forgotten easily because I don't really think that we think of fat pads as an injury area other than like your calcaneal like fat pad.
Yeah.
That's the only like thing I can really think of that in like quote unquote like school we learn about, where as I feel like when you think about that, you think of like a big contusion or a direct contact that causes injury, whereas this is more like faulty motor patterns and innervations and like things that can cause things to go right.
That's a good point, because about what kind of like school is like, I feel like we never talk like, again, like,
I mean, and that's not necessarily the point of school, is not to go over every single thing that you will see, because that's not possible.
No, that's definitely not possible. So now that we know that there's a fat pad there and it connects to everything, what the hell does it do? Why do we have this giant thing of fat pad in our knee? And that is actually a really great question. It's really not 100% known for sure what it does. It's kind of broken down into kind of two kind of purposes. One's kind of like a biomechanical purpose, and one's actually kind of like a biological response.
Interesting.
Biomechanically, it may assist in stabilizing the patella, and it could kind of help improve the distribution of force throughout the patellofemoral joint. I think like they did some cadaver studies where they took the fat pad out, and there was actually like increased rotation of the tibia. The patellas started to track more medially, which if you look at the anatomy of the femur, right, that medial condyle is pretty huge, right? It's pretty big compared to the lateral side. So if you have your patella crashing into that one, that's not going to feel very good. It can also change the angle of the patellar tendon itself. So it actually shortens the length of the patellar tendon, which makes the quads have to work just a little bit harder to actually produce extension. So inefficiency.
So it basically just barely changes the lever arm of it.
Yeah, exactly. Yeah, 100%. And then the kind of like the biological perspective, in which I kind of feel like this is probably what is the real purpose of it, is it serves as a storage for many reparative cells like mesenchymal stem cells, which if you're like, again, what the hell is that? It's just basically these cells that can differentiate into different types of cells depending on the location they're at and what job needs to be done. So this is huge in like cartilage repair or tendon repair. Like it can turn into like tenocytes and like stuff like that actually helps the repair process. So it can actually be very important to kind of joint health in general. And that's why another thing with the fat pad is there's a lot of literature on the fat pad and total knee replacements and osteoarthritis because of the dysfunction from possibly the fat pad or vice versa, the arthritis causing dysfunction.
Okay, so how does it actually, let's go back to the biomechanics of it, because that's that's how I treat fat pads is the biomechanics.
Yeah, absolutely. So it is in the knee, which is a fairly mobile structure, right? So it's got to be mobile as well. So what I think you don't really think about is the fat pad does move as we move. So as we go into knee flexion, the fat pad will actually travel posteriorly into the knee joint. I know, it's really crazy to think about, like it's going into your knee.
Like, what do you mean in the knee joint? Like in the joint space,
Yeah.
or like?
Yeah, it actually travels a little bit posterior, so actually like going in between the space between the tibia and the femur. Yeah, it's pretty trippy. And then during extension, it's going to do the reverse. It's going to kind of translate anterior and then go a little bit inferior to fill that space in between the patellar tendon and the tibia. So that little triangle, it's going to fill that in just a little bit. So it kind of does this like rocking motion basically during like knee flexion and extension. So if you kind of notice, like if there's any alteration to that fat pad, and where you really see the limited mobility is through scarring. So like kind of fibrosis around the fat pad can really change how our knee kind of moves. Like you can tell, like if it doesn't like slide and glide like it should, well, if it doesn't take the space during knee extension and it's still stuck in your knee joint, well, you're not gonna be able to fully extend your knee. You can see, you can see the limitation. But some other things that we kind of briefly touched on, right? It actually can increase patellofemoral joint reaction forces if it doesn't move quite right? So that's going to put a lot more compression on the patella against the femur, which could be painful, right? It's going to track more, the patella is going to track more medially, and it's going to hit the femur a lot sooner.
I mean, think about how often you have patellofemoral pain.
I know, right?
This is like so common. That's such a common thing.
Yeah. And so maybe we need to start thinking, hey, what the hell's wrong with the fat pad? Right? Like we said, it could decrease patellar tendon length, making the quads work harder. It can actually increase, this one was interesting. It can actually increase anterior translation of the tibia between 30 to 60 degrees of knee flexion. So just because it not moving, it forces the tibia to start translating just a little more anteriorly.
That's interesting.
Yeah. Isn't that weird? Which now you got to think like, oh, my ACL.
And the connections to the ACL.
Yeah. Right? So that is actually, it is a very biomechanically important structure. So now that we understand this is how it moves and this is what it does, and I now feel like I remember my anatomy class, now we have to talk about how do we actually evaluate the infrapatellar fat pad. And as you could imagine, there's really not a lot of tests for that.
You don't need special tests.
Well, honestly, yeah, a lot of it, you really don't need a special test for it.
Right.
It really boils down to palpation and just testing the mobility of it.
And history.
That's 90% of it right there.
Right.
For palpation, like if the fat pad is tender, it might be the fat pad. That again, it has a lot of nerves, so there's no mistaking if that thing hurts. But another thing that I learned from this, and what made me really think of one of my athletes with it, is the area of the fat pad is going to feel firm. And that's really weird because like that kind of spot in your knee tends to be a little squishy, kind of moved around.
Right.
But when it's firm, like you notice, it's like, this feels weird. So I think that's a really key thing. And that's what made me really start to think about it in one of my athletes.
Well, not only just firm, but like it doesn't move as well.
Yeah, it just doesn't move. It doesn't go the woo, woo, woo like it should.
Right. Almost like think of like if you're testing patella, like you know how you do like the medial and lateral glides, like that's how you should be able to do that with the patellar fat pad as well.
Yes, absolutely. So that kind of ties into that mobility testing. You should be able to glide it medial and lateral. And again, it should be like woo, woo. I wanted you to have that sound again in the car. You're welcome, everybody. So you could detect if it's kind of restricted in a certain way or both ways. You could tilt the patella posteriorly by pressing on the base of the patella and kind of like trying to get that inferior pull to push out anterior. This is kind of done with about...
Wait, pause. Say that again. You can tilt the patella.
Yeah, so if you push on the base of the patella, so the superior part, it should get the inferior pull to push out anterior. So like you're like pushing it like that. You're basically detecting, is the mobility the same between each knee? Like, do you get the same amount of tilt?
How are you telling between patellar motion and fat pad on that?
Well, because the fat pad attaches to that inferior pole, if there is any adhesions, you may not get as much tilting. So it may be limited. And that's where you could possibly assume the fat pad could be causing that. It could add a little more like kind of confidence in your evaluation of the fat pad. That's done with about 90 degrees of knee flexion, or 90, I'm sorry, 60, not 90. Don't do 90. That's bad.
You're not really going to get much
You're
motion.
not going to get much out of that. And then there is, again, this is what also made me think of it for one of my patients, is the possibility of limited range of motion, especially at the end ranges. So you're talking a deficit in extension, maybe a deficit at end range knee flexion. Again, there's a lot of structures that, well, not a lot of structures, but there are a lot of things that could kind of cause that. So it is important to kind of differentiate, is this the fat pad as opposed to like, oh, you tore your meniscus.
Yeah, that's kind of different.
So I think that is something to keep in mind. And again, going back to like the ACL thing, right? We're talking about people who were trying to regain, especially knee extension. And if you have someone that's lagging, right, you might need to start thinking, oh, I wonder if the fat pad's a possibility.
So you keep talking about ACL, and like I haven't really thought about this specifically with ACL, so I can't say that I've noticed too much with that clinically, but I find that when anyone comes to me with like patellofemoral pain, this is what I'm checking.
That's awesome.
And even with people who have concurrent patellar tendon pain, sometimes I feel like that creates a disconnect or a movement pattern change in that fat pad as well.
Yeah, for sure. Absolutely. And you could see like the healing process includes scarring.
Right.
So if you're having some increased scarring around the fat pad, mobility is a problem. But don't worry. Someone had to make a special test. And there is a physician that threw their name on this bad boy. And it's referred to as the Hoffa test. Hoffa was kind of like the big physician that really looked into the fat pad all the way in the early 1900s. Yeah. See, we've known about this structure for a long time as being a possibility of problems. And this test is really easy, and it can kind of help confirm your diagnosis that, hey, something's wrong with the fat pad. Is basically you put pressure just outside the margin of the patellar tendon, just inferior to the inferior pole. So like literally right on the fat pad, but not on the tendon. So you're off to the side of the tendon with the knee in slight flexion. And then you basically keep that pressure and then fully extend their knee. If there's pain, then you're like, okay, the fat pad could be the structure that's causing the pain that you're feeling.
Yeah. I feel like it's easier. I mean, you can do that with the motion.
Yeah.
I feel like you also don't need to do the motion. You can also just differentiate between like if like pain on patellar tendon versus like just outside the patellar tendon versus joint space. You can kind of see the difference.
Yeah, no, absolutely.
Right. But it is nice to be able to add that like motion.
Yeah, that just like a confirmatory test kind of thing. Yeah, I know. Special test.
What's the specificity and sensitivity?
You know what sucks is I couldn't find it. So who knows if this actually works? This could just be voodoo at this point. It could be worse than a coin flip. Who knows? But yeah, unfortunately, I couldn't. I did try to look for the kind of the metrics of that test. I couldn't find them. So if someone knows,
I mean, I feel like I've heard about this test, so I don't think that it's gone all the way in under a rock.
Yeah, I don't. Yeah, Hoffa. Thanks, man.
Or no, because I think, don't they call it Hoffa's fat pad?
Yeah, so when there's dysfunction, I didn't look into what truly differentiates it, but people have referred to it as like Hoffa's fat pad, Hoffa's syndrome, or Hoffa's fat pad syndrome, or something like that.
Okay. I was like, I know I've heard this before.
Yeah.
I don't know in what context, but
this structure does tend to be called Hoffa's fat pad.
Okay.
That was actually an important anatomy point to put out. So
you're welcome.
If you're halfway through this bad boy and now you know what Hoffa's fat pad is, you're welcome. Okay. So we evaluated. We've moved fat pads. You've forced someone's knee into extension while pressing on the fat pad. Now you gotta be like, all right.
At least it's not as mean as Clark's sign.
That's a mean test. Clark is mean. Can't believe someone thought of that. So now you got to do something about it. And our job is the non-surgical part. So there are some non-surgical options for the fat pad that we can at least implement a treatment and see, do we get improvement with? And really the goal of all of our treatments is to pretty much unload the fat pad and also try to relieve any scarring that might be restricting the motion of the fat pad and causing all of our issues. So there aren't a ton of interventions that specifically target the fat pad. Really, when you think about how do we handle any limited structure or limited motion in a structure, it's let's work into that. Let's kind of work on that mobility, stretch that structure out. And you can do that with the fat pad. You could do glides of the fat pad, right? That's what I've been working on with one of my athletes. You could like decompress the fat pad. Like there's a tape way that I just turned into like manual therapy. Like literally you're like pulling the fat pad anteriorly. So that one I've kind of seen some
Like with
pretty good success.
Luco? Do you use Luco?
We'll jump into the taping part, but
okay.
for the actual manual therapy, I just do it by hand.
Oh, sorry. I thought you just said taping for some reason.
No, it's based on the same idea as what the tape's doing, but we'll talk about the tape. You could also stretch quads and hip flexors. That's been shown to show a little bit of a benefit.
I mean, if you think about it, like, so here's like how I've approached it because I didn't look into this specifically.
Yeah.
I'm just looking clinically. So, your fat pad where it sits is like right underneath that patellar tendon. So if that patellar tendon is really taut, then obviously like you're going to want to stretch those quads, and anything like above those structures. So you are getting less pressure on that fat pad. I treat the fat pad specifically like when, almost like, when you're doing like patellar mobs.
Yes, yeah.
You can do that with the fat pad as well, like the
medial and lateral.
medial and
glides.
lateral. But you can also, what I like to do is apply similarly to, and I took this from like a Mulligan idea, where you know how in Mulligan you're treating the joint and it's like maybe like let's say your finger like flexion extension, right? Where maybe that's causing you pain. So then you just apply like a medial or lateral force to one segment and then you do medial or you do flexion extension. And I do that with the patellar fat pad as well. So I will take the fat pad and I will move like medially, for example, if that's I'll move it medially. And then I have them bend and straighten their knee. And if that feels better, then we're going to continue doing that.
Yeah, absolutely.
So then we'll do like a couple rounds of those. And then if it doesn't, then I'll do a lateral motion of just the fat pad and then just have them bend and straighten and see if that helps.
Nice.
And then you can also do that applying with like squats or like more functional movement. And so then that's and I know we're going to talk about taping later, but then that's usually how I apply the taping after is moving in like whatever that like motion that causes them less pain.
Yeah,
is.
absolutely. So yeah, now that ties in nicely with the taping. There is a specific tape application that you could do that's really geared towards trying to unload it. So if it is the structure that's irritated and it's taking on too much load, right, that's going to irritate it more. So bear with me, right? We're going to be describing it, so it's really always hard to describe it in words, but it should be a pretty easy tape. It is done with Luco tape from what I've seen. So you could probably modify how you want depending on...
You can always modify tape.
Absolutely. You can always get creative. You're going to do a first strip over the base of the patella to kind of tilt it posteriorly. All right, so you're basically on the superior part of the patella. You're adding a strip.
I don't like that it's called the base. Every single time it confuses me.
I know. And then that's going to tilt the patella posteriorly, so the inferior pole is going to push out a little more anterior. And then you're going to add V strips over the fat pad. So it basically starts at the tibial tuberosity, and then you pull towards like the different femoral condyles.
Okay.
But while you're adding the tape, you're actually going in and with your hand pulling the fat pad up and then putting the tape down.
So you're pulling the fat pad in the opposite direction of the tape. Perpendicular.
Yes. So you'd pull superior and then the tape would go just underneath it as it's...
More like pull medial or lateral, right?
The tape's pulling. But you would... Yeah, I guess you could kind of pull it to the opposite. Yeah. I see that. I see what you mean.
So your hand is pulling medial, for example, the fat pad medially.
Yes.
And then the tape is pulling the fat pad laterally.
Well, the
You're
tape's
making like an X.
you kind of, yeah, you're trying to make a V, and the tape basically goes under to keep the fat pad from falling back down.
Yes.
And then you could add a final third strip if the V strips didn't help or didn't fully take it away. And that third strip just goes over the posterior lower leg, so just inferior to the popliteal fossa, and basically you're just pulling the tibia anteriorly.
Interesting.
I know. Basically, your goal is to almost create this like muffin top on the anterior knee.
That's hilarious.
I know. They actually did say muffin top.
Oh my gosh.
In the literature.
Do they have pictures on this article?
Yes, there were pictures of it.
Okay.
Yeah.
It's in the references.
Yes. So you can find it. I believe it's any of the articles that discuss evaluation treatment. Both of them, because I think there are really only two that really dove in. Both of them do talk about the tape application. Yeah, that's supposed to unload it. And again, you should kind of look at your knee and be like, why does it look funky and all bunched up? Well, that's what you're trying to do.
This is also really helpful when, if you're having someone who you think has patellar, I keep saying patellofemoral, which I guess it kind of is, but not really. When they're having patellar tendon pain and you do a patellar strap and it doesn't help, that may indicate that they're having fat pad issues instead, because you're just compressing the fat pad and causing more pain rather than allowing it to move, which is how I differentiated on my own knee, which is why this is something that I've delved into.
Yeah.
Because like you can tell the difference, like if you press like right on patellar tendon, it's not painful, but if you press on the outside,
Oh, wow.
yeah.
Of course, no taping is ever complete without the strengthening component.
Yes.
And the strengthening concept for the fat pad is very similar to what just we've always talked about on the podcast, especially with knee pain, is there's going to be inhibition of the quads. The quads are going to want to start turning off. So you do still want to strengthen quads, but there is some caveat. You want to be cautious with full extension motion, because again, that puts a lot of strain on the fat pad, especially if it's not mobile. So if it's already stuck and it's not being able to translate anteriorly with knee extension, and you're just going to go in and do like quad sets and like straight leg raise, right? That could irritate it if it's already irritated. So you may have to kind of avoid that at first and use more of your closed chain activities. So like squatting and stuff like that. That might be a good place to start, especially if it's really tender. And then
and try with the little mobilization too. Like try that mobilization while they're squatting and see if you can get some pain-free motion.
Yeah, and honestly, you could try that with the quad sets or the straight leg raise to see if that helps, right? So if you unload it and they're able to do that exercise pain-free, then heck yeah, why not? Let's do it. And then, of course, no knee rehab is complete without talking about your glutes and core, right? Because all those things are going to help protect the loading of the knee and kind of provide a good support system for the muscles that surround the knee for them to act appropriately and actually act efficiently and effectively.
Okay, so I got a little buy-in tip that I've been using.
Okay, go for it.
So, especially with some macho athletes who don't want to hear that they're weak, which I mean, technically, it's not always an issue of it being like quote unquote weak, right?
You can't control it.
Some wording changes that I've used lately that I have found has gotten more buy-in is we talk about, like the education piece, we talk about how you could have the strongest glutes in the world, and if they're not firing at the right time, they're not doing their job properly. So, and that gets in their mind because they're like, oh, like I'm not weak, like I have strong glutes, but I need to work. Like that's why I have to do the rehab, because it's got to turn on at the right time. I've got to activate it at the right time. And so now I say like it's a movement pattern issue that we're changing, which is true.
Yes, it's very true.
So that really gets their buy-in on doing a lot of these smaller things that I'm like, I just want to get the glutes firing. I just want to get this working, and then that's going to help you with your knee pain. Or like you're not getting any dorsiflexion, you're not getting any
Yeah.
hip extension, you're not getting any glute firing. Like, I need all those things. You could have the strongest glutes ever, but it's not gonna help.
Yeah, if it's not turning on when it needs to, that strength doesn't even matter anymore.
Mm-hmm.
Yeah.
Do you have an action item for this?
If you're stuck on the knee, think fat pad.
Yeah, I like that.
Rule it out.
And it doesn't necessarily have to be the only thing going on. Like, it can be in addition to the things that you're treating.
Yeah. Well, because you got to think, if there's an injury to the knee, fibrosis, the scarring, right? Well, now it could be affecting the fat pad too, which then just perpetuates the problems.
Right.
We don't want to perpetuate problems.
No.
Perpetuate solutions.
Ooh.
Dropping pearls here.
I feel like there are a lot of P's in the last 30 seconds of this episode.
This whole episode. Infrapatellar fat.
Yeah, okay, that's fair. So if you guys are new, our references are on our website. This is good for CEUs. As we said before, make sure you check the show notes for all those fun goodies and the things I'm about to say as well, because we don't just do CEU episodes here on AT Corner. We also do story episodes and interview episodes. So story episodes are episodes where we take stories from real life athletic trainers and we share them on a highlight topic. Like, we are just about to do a one on admin stories, so that's upcoming. We put our story prompts up on our Instagram stories, so if you don't want to miss those, make sure you head to our Instagram page so you can submit your story. We also do interview episodes where we bring in experts in their topics so they could talk about things a lot better than we can. So with that, actually, one more share. We also are still working with MedBridge, and you can get $101 off your subscription if you use code ATCorner, and that gives you a full year subscription of CEUs. Absolutely. So now would be the perfect time to look into that as well, because you are not only getting not this year, you're still getting a full year, but you are getting 2026 and into part of 2027 now. So depending on when you're listening to this. Cool. I think that's all I have.
Thank you for helping us showcase athletic training behind the tape. Bye.